cloud. Sorry. All right, so the reason the endocarditis is so important to us is because there is a high risk of mortality if not diagnosed. So there's high mortality rate and high risk for developing complications. High risk of developing complications. And patients who have upsign higher risks or increased risk factors. Those are patients that have prosthetic valves. Those are patients that have native valve disease. Patients with congenital heart disease. Congenital heart disease. And IV drug users. All right, so symptoms. Like we were talking before with some of our cardiac masses, we can distinguish cardiac masses from like endocarditis based on patient's symptoms. So with endocarditis, these patients are sick. They have an infection in their heart, an infection that's raging that could potentially become fatal. So these patients are going to have symptoms. First symptom is going to be fever. They'll have fatigue. Weakness. They may have flu-like symptoms. Potentially weight loss. So there may be some vascular phenomena which occur. So sorry. So these are different vascular phenomena or occurrences. So one of them is called petechia. So this is described as a subcutaneous dermal red spots. Subcutaneous dermal. We think of dermal within the skin. Dermal. I'll put skin. Red spots. Red spots. So this is kind of like a rupturing of like small little capillaries. It's usually due to like microemboli reaching the capillary beds, and you develop these little patchy red spots in the skin. You can wind up with another condition called splinter hemorrhages. These are reddish thin lines appearing under the nails. Splinter hemorrhages. That's red, reddish, thin lines appearing under the nails. Nails. A condition called Osler's nodes. Osler's nodes. So this is red raised tender lesions on the palms and soles. Red raised tender lesions. Palms, soles. Green. So this was a picture showing that. So these are some vascular complications that could result typically from embolization of the vegetation. So you wind up with these almost look like gangrenous, like cyanotic lesions. So then the last one would be something called Janeway's lesions. These are purplish lesions on the palmar surface of the hands. Janeway's lesions. Purplish. Lesions on palmar surface of hands. ulnar surface. Hands. So with any vegetation, we also run the risk of embolic events. So another thing could be embolic events. So these can be both systemic or pulmonary. So you can have systemic embolus. So under systemic embolus, where is it going to go? We're talking the left side of the heart. So that could be, CVA, stroke. Could be distal extremity. Embolus. When we're talking, when distal extremity embolus, that would be like cyanotic, / necrotic. Digits. So those would be patients that have blue fingers, blue toes, because they've now had embolus go out to these small little arteries blocking the circulation. I know you don't talk about it, but sometimes embolus can even wind up, reaching the arteries of the organs. I had a patient who had, systemic embolism, and I saw it when I was scanning a DVT study, and his popliteal artery was occluded with like crushed thrombus, and it just, like I'm going in grayscale, and like I was like, what is this? Like, oh my God, it's like fresh clot. So, I took extra pictures, imaged it, and they, sent the guy for a body scan, to check the rest of his arteries to see what the story was. And he actually had embolism in his renal arteries, like, so he's going into renal failure. So I probably saved that guy's life, finding that. And he turned out he had like a big, huge clot in his heart that was like just ready to go too. So thank God he hadn't gone to the brain and created a stroke. So then pulmonary embolism, your other embolic event, and we know pulmonary embolism is going to go to the lungs. Could be our PE. A couple other physical findings. The patient may have something called clubbing of the fingers. Clubbing of digits. It looks kind of strange. So like if you have like let's draw a hand. Oh God, I'm terrible. So if you have your normal hand, the distal portion with the nail actually kind of like gets like big and rounded, and it almost looks like a club. Like instead of like having a nice normal nail bed and tip of your finger, you get like these little, they almost look like clubs. They come like almost rounded and dilated. patients may also have splenomegaly. And any other findings that might be consistent with valvular regurgitation or valve obstruction. So any additional findings consistent with valvular regurg or obstruction. So then again, we talked about the common locations. So common locations. Say atrial, side, cuspid, and mitral valve. Ventricular side, colonic and aortic valve. And also secondary to any jet lesions. So less common locations, we're going to be on the chordae. Less common locations. On the chordae. Mural endocardium. The chamber walls. Actually, we'll put that under mural endocardium. Chamber walls. Less common also would be on the prosthetic valve sill ring. We may also encounter them along pacemaker wires. This is also less common, pacemaker wires. And the eustachian valve. So appearance. What are vegetations going to look like? All right. So appearance. So they're going to be echogenic. They'll typically be irregular shaped. They'll appear pedunculated, so they'll look like they're connected by a stalk. So they'll often flutter or vibrate. Often flutter and vibrate. So you'll see these things flopping around in the blood flow. Vibrate. So they rarely impair valve motion. So they don't really affect how the valve actually moves, but what they do affect is that valve closure. So they rarely impair valve motion, but often affects I want to say coaptation of valve leaflets. That's why often associated or has association with regurgitation. With regurg, regurgitation, and obstruction. Vegetations must be greater than 2 millimeters in size for detection. Must be greater than 2 millimeters in size. Detect. Another thing that we have to remember too is that the infection can cause valve perforation. So can cause valve perforation. The vegetations can potentially cause abscesses. So abscess formation. They can potentially cause dehiscence of prosthetic valve, or dehiscence, sorry, DE. Where am I? Dehiscence of prosthetic valve. And remember, dehiscence is a separation of that valve from the annulus. That's a major concern. And with pretty much anything, that we're concerned about with regards to intracardiac masses, TEE is superior to transthoracic echo for visualization. I just uploaded a couple of clips onto D2L, just so we can all see Vegetations. Screen, wait. So this one had obvious one on the aortic valve, so you can see it's on the ventricular side, the aortic valve. Apparently, there's also a small one on the mitral valve. I think I see it when they go in the 4-chamber view, come in and out a little bit. And you can see that obvious one on the aortic valve. Looks like that looks like the LVOT. I thought I saw. Again, you see it flopping around. It's echogenic, it's irregular shaped. And these patients will have symptoms, of infection. They're going to be sick. So that's when you really have to raise that red flag, like, all right, this is most likely endocarditis. Oh, here we go. There's and I threw one on here with a prosthetic valve.
Hi, engineers. What we're going to do in this video is we're going to talk about the basics of EKG. This is a really important diagnostic tool.
Oh, what happened there?
It's important for being able to look for arrhythmias, being able to look at.
I don't want you. So this is a prosthetic aortic valve. So you can see the shadowing actually of the valve. Play that again. You can see on the mitral valve vegetation how it goes up and down, flutters around. And you can notice with the aortic valve, you get this shadowing on the annulus where the valve is sewn in. TEE. So you can see TEE is a much clearer picture. Right, so All right, so again, so some more complications. All right, so we talked about, valve perforation, mentioned abscess. So I'll actually add a little bit to abscess. So the most common location is going to be near the annulus of the aortic and mitral valves. So for abscess, most common location is at annulus of the aortic valve and mitral valve. Endocarditis can also lead to aneurysm. And that usually involves the aortic root or sinus of Valsalva. Usually involves aortic root and sinuses of Valsalva. If we go back to our talk about aneurysms, when we're talking about the sinuses of Valsalva, the most common cusp involved would be that right coronary cusp aneurysm. Another potential thing that could happen would be a fistula. So a fistula is an abnormal connection between two systems or two areas. Again, we mentioned dehiscence of the prosthetic valve. You can add on here pericardial effusion. The last thing is going to be hemodynamic compromise. Dynamic compromise. Compromise. God, I am terrible. Compromise. So hemodynamic compromise. So under hemodynamic compromise, yeah, regurg. And that could be acute or chronic. Acute or chronic. valve obstruction or stenosis. Obstruction / stenosis. We could have the development of intracardiac shunts. Intracardiac shunts. Patients can develop CHF, congestive heart failure. So patients can potentially develop a cardiac tamponade. Due to that abscess formation at the annulus, we may also have perivalvular regurgitation. Perivalvular. So that abscess formation at the annulus potentially cause the dehiscence and that separation and wind up with perivalvular regurgitation. So not only with the prosthetic valves, potentially be with our native valves as well. So I was reviewing actually with the second years, like for their registry, and we were talking about tamponade. So I don't know if like I necessarily like explained it, well enough, like, to really understand, like tamponade is just a condition where we have hemodynamic compromise of the heart. So the hemodynamics of the heart have reached a critical, I don't want to say like obstruction or critical interruption as a result of the pressure of the fluid building up around the heart. And what's happening is we're actually getting an equalization of pressures within the heart, and the blood flow is essentially coming to a stop or slowing down. So that's the hemodynamic compromise. So everything is kind of almost coming to a halt with cardiac tamponade, all the blood flow within the heart, because it relies on those, changes in pressure. And associated with tamponade is something called a quiet heart. So that was like a question that kept coming up on our registry review, associating tamponade with something called the quiet heart. So the heart sounds actually become quiet because the blood flow through the heart is slowing down. The heart becomes tachycardic with tamponade because it's trying to circulate that blood, so it's pumping faster, but it's not really, successful. That's why tamponade, is, a critical thing when we start, making that diagnosis for tamponade. Just wanted to touch base on that a little bit more. So prosthetic valve endocarditis. Prosthetic valve endocarditis. So vegetations on prosthetic valves are difficult to diagnose due to the high reflective nature of the valve and shadowing created by the prosthesis. So the actual placement of the valve itself being implanted into the underlying tissue. So, depending on the valve, if it's a mechanical valve that's metal, we'll get a fair amount of shadowing. Vegetations. Vegetations. Valves. Difficult to visualize due to shadowing and high reflective nature of valve. So distinguishing vegetations from the prosthetic material or the sutures that are used to hold the valve in place, the prosthesis in place, can sometimes be difficult. Difficult to differentiate. Between prosthetic material and sutures. Sutures. So again, our transthoracic exam is usually inadequate in imaging prosthetic valves for vegetations. Unless the vegetation, is very obvious, if it's extensive, large vegetation. So, and TEE is best method. Diagnosing endocarditis with a prosthetic valve. So infected intracardiac devices, the prosthetic material is difficult to treat for endocarditis without removal. So these vegetations, they're a tough, nasty infection. And they can be very difficult, to treat and to remove. I know in my experience, I've had some young people with endocarditis. They haven't necessarily had prosthetic devices, but they're in that cardiac ICU for a pretty long time, getting intravenous antibiotics, continual monitoring. They're getting an echocardiogram usually every other day just to make sure that the hemodynamics aren't becoming compromised. So with infected intracardiac devices, devices. Infected let's say prosthetic material. Is difficult to treat. Without removal. That's why patients with prosthetic valves are typically treated with a prophylactic antibiotic, before they go for dental. You see Alana's shaking her head for dental procedures. Is it even for like routine cleanings sometimes, or no? Just for dental procedures.
Like even when they have a teeth extracted, patients also take antibiotics just in case.
Yep. I know my sister, when she was little, she had a heart murmur apparently, and like when she'd have to go for her cleanings and stuff, like they always put her on some antibiotics beforehand. So also distinguishing vegetation from thrombus with echo alone is virtually impossible and requires clinical correlation. That's another thing to remember. So again, we're looking at that patient's symptoms. Are they sick? Do they have the fever? Do they have signs of infection, elevated white count? Thrombus can produce that, but these patients are typically going to be sicker with endocarditis, And we also have to look at their histories, with IV drug users, with the right side of the heart. So we have to put all the clinical pictures together, to distinguish between thrombus versus vegetations. So right-sided endocarditis. So with this one, most commonly seen on tricuspid valve. Tricuspid valve. Why? Because that's the valve that the blood's going to hit first. So it's going to get to that tricuspid valve before it gets to the pulmonic valve. Again, on atrial side. So vegetation size tends to be larger in right-sided endocarditis. Vegetations. regurgitations tend to be larger. Right side. Usually associated with some degree of tricuspid valve regurgitation. So you're more often than not, you're gonna see some degree of tricuspid regurg. So pulmonic valve regurgitations are less common and can be difficult to visualize. Pulmonic valve vegetations, veggies are less common and difficult to visualize. So rarely, pulmonic valve vegetations can also occur as a complication of pulmonary artery catheterization. We'll put under may occur as a result of pulmonary artery catheterization. Got a man in the room tonight. Catheterization. All right, so some differential diagnoses. I think you guys could probably throw a couple at me.
Would thrombus be one?
Absolutely, thrombus. About any cardiac tumors or masses that could potentially be. It's the one for the valves, capillary fibroelastoma. Lamb's accessorants, those are those fibrous valvular strands. So differential diagnosis. Differential diagnosis. So we'll put up here non-bacterial. Thrombotic. Endocarditis. bacterial thrombotic endocarditis. So another differential diagnosis, we have to diagnose between active versus healed vegetations. I'm spelling that wrong. Vegetations. It's like, capillary fibroelastoma. Elastoma. Lambs. Accessories. Your fibrous valvular strands. Valvular strands. So we could potentially mistake sutures or strands from prosthetic valves. Prosthetic valves. So focal non-specific thickening or calcium deposits on the valves. Focal thickening. Or calcium deposits. Valves. So again, absence of any clinical signs of infection should lead us to look for other differential diagnoses. So if they're negative blood cultures and there's no sign of infection, it could potentially, be something else that we're fishing for or something else that we should be looking for. So. Again, so negative blood cultures. Negative blood cultures. Black. Signs of infection. Should have us looking for a differential diagnosis. Have us looking different diagnosis. Again, that's an important point to just bring home. It's all about those signs and symptoms. Are they sick? So again, underlying heart disease can sometimes obscure the presence of vegetations and increase the likelihood of a false positive finding through misinterpretation. All right, and the last slide is going to be treatment. So we have medical treatment and we have surgical treatment. So medical. So under medical, like I was mentioning before, you can put prevention. So prevention, that's going to be our endocarditis prophylaxis. So that's going to be, antibiotic, prophylaxis. So if the patient has endocarditis and it's, positive, their cultures, they're going to have antimicrobial therapy. Antimicrobial therapy. So basically that's going to be IV antibiotics. We'll also treat them with medications for heart failure. So if they have hemodynamic compromise, treatment for heart failure. So that would be, our ACE inhibitors, or calcium channel blockers, ACE inhibitors, or CA channel blockers. Diuretics. Anything that's going to help out the heart, take stress off the heart. And then the last medical treatment could potentially be anticoagulation if clinically indicated. So if they've had embolic ischemic events where those vegetations have gone to those distal extremities and, they have hemodynamic compromise in their extremities, we need to anticoagulate them to try and, increase perfusion to the extremities. It's a vegetation that's potentially gone to the lungs and caused a PE. We want to anticoagulate, so we're getting good blood flow to the lungs. So Coagulation therapy, if clinically needed, anticoagulation therapy. If needed. All right, anticoagulation medications, that's gonna be our heparin, Lovenox, Coumadin, warfarin, Xarelto. I mean, there's a whole list of anticoagulation therapies. I don't think you'll necessarily need to know those, as it regards to endocarditis for your registry, but. And the other treatment is surgical. And surgery involves valve repair or replacement. And surgical. That is valve repair or replacement. Howdy. Yeah, another semester done. Almost. All right, any questions about endocarditis, these vegetations? Not really. It's not too bad. Bacterial infection, most likely to attack the valves. It's a common location. So that Staph aureus is typically right side with IV drug users, tricuspid valve. It's atrial side of the tricuspid valve. The side of the valve that the blood hits first. They're mobile, they're irregular, they're echogenic, you'll see them flopping around. These patients will have symptoms, they'll have fever, fatigue, they'll be sick, positive blood cultures. TEE is the best way to get a good look at it. Yeah, I mean,
And
yeah.
do you happen to have like a list of like the values that the ASC uses like to determine mild, moderate, and severe?
For like stenosis and regurgitation.
Yeah, like it's like a big list that we were given last semester, but I don't know what I did with it.
Sure.
Same,
Yeah.
girl.
I will, yeah, definitely. I will scan that in and upload it.
Thank you.
Sure.
Cool. Thanks, Dan.
Any questions?
No.
No. Class dismissed.
Cool.
Neat.
Yeah.
Bye, guys.
Hi, guys. See you all next week. I want pretty pictures.
Yeah. We're artists here.
Oh, I'm an artist. Sure. My club fingers.
I love the club fingers.
There's a picture of it on D2L. It's kind of, it's gross.
Then can you post it like on D2L? This TEE views. I
A
mean,
picture? Yep,
yeah, picture.
Yep.
Thank you.
you got it.
And next Friday is our quiz, right?
Last quiz, yeah, so that's gonna be what, endocarditis, what was the last, I don't even remember what the last lecture.
And tumors.
And tumors.
Whatever we did last week.
Whatever we did last week.
Aortic diseases.
And aortic disease, yeah.
Aortic diseases, yes.
Cool.
Cool. We have 8
Yeah.
more tests to go.
Eight more tests. Stop counting.
Yes.
I know.
All good.
All right. Have a nice weekend.
You too.
Bye.
Bye. See you.